We're going to go through stuff related to spine trauma. And we're going to do this the fun way, which is I'm going to randomly pick someone who is going to be on the hot seat as we go through this so that we are paying attention, right? But also engaging audience participation. So the first person who is up is Osama Kashlin. Where is Osama? Let's get Osama a mic. Do you sing, Osama?
Do I sing?
Yeah.
Not well.
Not well?
Karaoke style.
Right on. Seattle's got some hot karaoke joints, as Juan Uribe introduced me to a few years ago. You remember that? Oh, man, that was fabulous. All right. These are my disclosures. Okay, we're going to do this in the context of evidence-based guidelines as were published in 2013. We have at least one participant from that effort who's here today. I hope Nick. Oh, Nick's getting a massage right now. So when he's back from his massage, we'll talk about the ways in which he was an active contributor in screwing this up. Okay, but we'll get to that later. So these guidelines are based on scoring of evidence based on level 1, level 2, level 3 data, right? And level 1 is really randomized prospective clinical trials, and then in the old days, it was called standards, guidelines, and options, but now it's level 1, level 2, level 3 recommendations that should be reflective of the quality of evidence that underlies that. Okay, so Osama, 57-year-old lady, falls back off her bar stool, right? This is a daily occurrence in all of our lives. It's amazing how people are sitting on bar stools at all hours of the day, right? So it doesn't matter whether it's 10 in the morning or 10 at night, there's the opportunity to fall off a bar stool. And then she hits the back of the head of a bar, hyperflexing her neck. She has had a history of a, quote, prior neck fusion, and you're called to the ED to clear her cervical spine. Okay? So what's going through your mind as you are called to do this?
Is she awake?
That's a great question. So what clinical information would you like to know? She is a GCS 15.
And is she having any numbness, tingling, or did she have it when she fell off the bar stool?
She denies any and all symptoms.
No neck pain?
She's complaining of some neck pain, but denies anything besides neck pain.
So nothing other than neck pain, just a little bit. Okay. I would ask her to maybe flex her neck, extend it, and look side to side and see if she's having any midline.
So when you do that, what are you fulfilling? What is that called when you ask someone to do that? Does anybody know? The nexus criteria.
Okay, yeah.
Do you know what the nexus criteria are? Okay. Well, it's basically a large data set that shows that if you can do this and this and this and this, and you don't have midline tenderness, and you're awake, and you don't have distracting injuries, and you're not intoxicated, and you have an intact exam, then you're done. You don't need to do anything else to that patient according to the nexus criteria. Yeah. So in this situation, though, she's complaining of pain, and she falls off a bar stool, right? So the other thing you're going to want to assess is she clinically drunk, and what is her blood alcohol level? Okay. So her blood alcohol level is 450. And she has slurred speech, but she's neurologically intact. Okay? So what imaging are you going to get?
I mean, I think in that case, if she's intact and she has a little bit of neck pain, I would leave her in a collar and examine her later.
You're not even going to image her?
I mean, if she's intact and just a little bit of neck pain and it's just to fall off a bar stool, nothing, not a car accident or anything like that.
What about this little thing where she has a history of a prior neck fusion? You're not even curious at all whether she's broken her neck.
I guess you can get an X-ray.
You probably want to get at least some X-rays, and which is what happened in this situation. So she had this previous C12 wiring, but we'll talk about this in a second. As it turns out, X-rays really don't have a role in the management in the assessment of a potential cervical spine injury anymore, because they're actually terrible at identifying fractures. They're pretty good at identifying dislocations as long as it's not at the cervicothoracic junction, but fractures themselves, X-rays don't do a very good job at identifying them. But in this situation, she did get X-rays first, and then in this situation went on to get flexion extension films, and she's pretty okay from a flexion extension standpoint. But let's talk about a slightly different scenario. Because the real way to assess that person in 2015 is you get a CT scan of the cervical spine. And pretty much in every trauma center in the Western world, that is the way it's done now. We have abandoned the AP lateral swimmer's view and open mouth odontoid, right? We have pretty much abandoned that in the trauma bay and in the ER for the evaluation of cervical spine trauma. But here's a little different one, okay? 20-year-old male who's a GCS5 after a motorcycle crash, and comes in through the trauma bay and gets a helical CT of his cervical spine with 1.25 millimeter slice thickness, and it is normal. What are you going to do with that person's cervical collar? Yep, still you.
So I would leave the collar on.
Why?
Just because this patient's probably going to get moved around multiple times. We don't have the MRI by this point, right? Or do we also have?
Well, that's the question. Are you going to get an MRI in this patient?
So if I only had that CT, I would leave the collar on initially, and then if
What if I said to you that you had to wear a cervical collar for however long you made the patient wear a cervical collar? What would you do?
If I was lying in bed, that would be fine, I guess.
Right.
Yeah, but
Okay.
if I'm moving around,
You're just going to take a week off, lie in bed with a cervical collar, catch up on your soaps. Is that what you're going to do? Okay, who would take the collar off after a negative CT of the cervical spine? All right, we're at like 40%. And why? Why wouldn't you take the collar off? Who are you? Rich. Where are you from?
UCLA.
UCLA. Are you going to take the collar off?
Well, our institutional practice had been with traumatic brain injury patients, we'd probably leave the collar on because we're going to get an MRI for their brain. We're going to tag on the
Yeah, 5 days later.
in a couple of days.
Yeah.
But I think
A couple days later, they still have an ICP monitor in. Oh, now they're in ARDS. Oh, shoot. Now the X-fix on their femur fracture can't get cleared, right, by the radiologist. So now you're at post-trauma day 10. The cervical collar's still on.
Yeah, I think with the negative CT, the chance of there being an injury is pretty low, and I think there's been a couple of studies that have shown that, and there's some people that would advocate just for taking it off, and in those situations, often we'll just take it off at that point.
Yeah. What if I told you that the sensitivity, specificity, and positive predictive value of CT scan is vastly superior to the Nexus criteria? Would that change your mind? Because we apply the Nexus criteria every single day. And the Nexus criteria have a sensitivity and specificity of 96 and 90%.
Yeah.
CT scan is 99.999%, and it's 100% positive predictive value.
Then take it off.
Right. That's what I would do. I would just take it off. And so what do the guidelines say? As it turns out, there are lots of studies, and one of our residents did a very nice meta-analysis, 14,327 patients. There were 3 missed injuries out of 14,000 plus patients, and you could argue that 2 of the 3 actually didn't require treatment. So there was basically 1 unstable injury missed out of 14,000. And the conclusion was that if you just take the cervical collar off with a negative CT scan, the average level 1 trauma center would miss a fracture once every 14 years. Okay? Which doesn't mean that once every 14 years someone would sustain a neurologic devastation. It just means you would miss an injury once every 14 years. The guidelines, level 1, high quality CT. And then level 2 is involving the spine specialist. And this is what we do at Pitt, is when it's an obtunded or comatose patient, after the CT scan is negative, the trauma guys just call us, because a lot of times we're not consulted on these people if they don't have some reason for it. If they're intubated for their open abdomen, we're not consulted if they don't have a head injury. They'll call us and say, hey, can you help us? And then as long as the attending radiologist has said the CT scan is negative, and one of our chiefs or one of our attendings has looked at it and said the CT scan is negative, because they will miss the fished mouth disc space of ankylosing spondylitis. They will miss the atlanto-occipital dislocation, but Dr. Theodore shows you today how you should never do that again, because if you apply Peng's measurements to the O-1 joint, you will never miss another atlanto-occipital joint, atlanto-occipital dislocation. Or what is it, the interior, what did he say? The interior decapitation. So then we take a look at it and agree, and then we just take the collar off. That's what we do. And it's not that onerous, because it's not that often that they ask us to do this. But when they do, it just engenders a lot of goodwill and collegiality, and then they call you for a bunch of other stuff too, which is nice, for stuff you want to do. But then if you look here at level 3, it says DC collar at discretion of MD. So this is in the guidelines, where you are empowered to simply remove the cervical collar with a negative head CT. At some point, can I tell you that, like Adam Cantor and I, we were in Rod too. We all spent a year in New Zealand as neurosurgeons, and I was in there, and it's like August. You get there in June. It's like August. I'm drilling an ICP monitor in some guy's head, and I'm like, "Where's his cervical collar?" And the intensivists are like, "What do you mean? His CT scan was negative." And I said, "Well, I don't care if his CT scan's negative. This is 2004. It's like, you can't take his collar." And they said, "Well, look, we've been doing this for 15 years. We just take the bloody collar off." So the rest of the world just takes the collar off. And it's only because of lawyers that we're even remotely talking about this in America. But with 100% positive predictive value and a 99.99% sensitivity and specificity, you should just take the freaking collar off with a negative head CT. And then this is what I was going to say about the plain films, is plain films miss 48% of all fractures, and they miss 17% of unstable fractures. So plain films really don't have a role in the acute assessment of cervical spine injury. Okay, so next, page 2. We don't want to, if you're towards the end of the alphabet, we don't want to shortchange you. Where is Andrew Shaw? Andrew, what do you want to do with your life?
I want to go into private practice.
Right on. You can join the discussion back there as Charlie and Dr. Costa review their JAG collections. He's got the Laser Spine Institute. There's a position waiting for you at the Laser Spine Institute.
Do they have a position?
I admire your honesty. That's wonderful. Do you envision yourself doing spine surgery?
Oh, yeah, of course. Yeah.
Okay. And do you envision yourself taking call in a trauma center?
Yeah, we're a level 2 trauma center where I'm going.
What's that?
It's a level 2 trauma center where I'm going.
Oh, you already know where you're going. Oh, where are you going?
In Florida. Where? Not the Laser Spine Institute.
Not the West Coast Laser Spine Institute. You're going to the East Coast Laser. All right. So.
It's in Ocala. It's a small. Yeah.
Fantastic. Listen, the preservation of spine, of the value of spine surgery, okay, is directly contingent to our willingness to care for the trauma population, frankly, because when we're up against all the other specialties, it's a zero-sum gain. If someone wants to increase reimbursement for something in obstetrics, it means that someone else has to lose, right? So the value of what it is that we do is preserved frankly, because we're the only people who can take the epidural hematoma out of a 19-year-old kid's head so he doesn't have to die an unnecessary death, and because we can handle stuff like this. So when we walk away from this, we're shooting ourselves in the foot. So I congratulate you for taking a position where you will be taking call in a level 2 trauma center. You are doing your civic duty as well as the preservation of our specialty. Okay? All right. So you are called to the ICU to write admission orders on a 21-year-old who has just been involved in a motor vehicle crash. GCS 15, blood pressure 84/47, pulse 44, 5 out of 5 deltoid and biceps, 4 out of 5 wrist extension, 3 out of 5 triceps, 2 out of 5 distal to that, with a variable sensory exam. Okay? Got it? What's the neurologic level of injury?
It was his hand intrinsics and his tricep, so C7. C7, I don't know, his sensory, it's what, 2 out of 5?
How do you determine, what is the definition of the neurologic level of injury?
It's the last normal level.
The last normal level.
So it'd be a C6 Asia.
What does C6 do?
C6 is biceps. Wrist extension.
According to the Asia
Wrist
form,
extension.
wrist extension. Is wrist extension normal or abnormal?
No, 4 out of 5. Okay, so it's C5.
Okay.
Deltoid. His deltoid's normal.
All right. He is a C5. And what is his Asia grade?
So he's less than, was it less than 50%? Or less than anti-gravity? I can't remember, it was 4 out of 5?
What's his Asia grade?
So he's a Asia C.
Is he correct? Yes. Turns out he's right. All right. Does everybody use this thing? If you don't, you're not performing your duties correctly. Every single person with an acute neurologic deficit referable to a cervical spine or any spine fracture or injury should be assessed according to the Asia classification, which really is supposed to be called the INSCI instead of the Asia, but no one will call it the INSCI. Everybody still calls it the Asia score, or the Asia grading scale. So you have 5 important muscle groups in the cervical region, 5 important muscle groups in the lumbar region. You should know what levels correspond to each of those things because this is how you end up determining the neurologic level of injury. And then when it comes to the Asia impairment scale, A is that you have lost everything, so that's a complete spinal cord injury. B, C, and D are incomplete injuries. E is normal. B is you have sensory but not motor preservation in at least the sacral segments. C is you have motor preservation, but more than half of the muscle groups are less than anti-gravity. And D is you have motor preservation and more than half of the muscle groups are greater, are anti-gravity or greater. Okay? So everybody got that? And E is normal. The majority of spinal injuries nowadays are incomplete injuries. 40 years ago, it was the other way around. Most injuries were complete. Now most injuries are incomplete. And the distinction between an Asia A and an Asia B ends up being the single most important distinction. And that is the single most important distinction because of the massive variation in prognosis between those two groups. So 11% of Asia A's improve, and 44% of Asia B's improve. And in fact, most patients who are in Asia C have some degree of functionality outside of a wheelchair, often with orthoses. Many of them could use braces and such and walk, but it turns out to be a bigger pain in the neck than otherwise. So they actually just prefer the wheelchair. And when you talk to this patient population, what do they put as their number one priority? The one thing that they want to make better in the spinal cord injury population is what? Anyone? What? That's number 2. Mobility is like 5. Walking is 5th. Bladder function is number 1. Number 1 by a long shot. Number 1 priority is bladder function. Number 2 is sexual function. Number 3 is pain. So An Asia C has a very high likelihood of having normal bladder function. And lots of Asia Bs do too. So the critical distinction is the distinction between an Asia A and an Asia B because of the massive difference in prognosis and the massive difference in quality of life between those two. And then you have to remember that the first reliable Asia score is at 72 hours. And the perfect example of this was when Kevin Everett was injured on the field during a kickoff in a Buffalo Bills game. And he, as it turns out, was an Asia C on the field. So even before he got to the ER, if you're an Asia C, I mean, you're going to walk in a year. The Asia Cs are going to get better and walk. But, a press conference is held that evening saying he's never going to walk again. And then 3 days later, it's like, oh my God, it's a miracle he can walk. And it must have been the hypothermia, right? It wasn't the hypothermia. It was the fact that he was an Asia C. Now, did the hypothermia help? Who knows? Maybe. There's a plausible reason to believe that the hypothermia helped. But the real issue was that he was an Asia C. He wasn't an Asia A by the time he got to the ER. So, yeah, he's going to walk. All right. Why is it that Asia Bs have such a massively higher, a 4x higher rate of improvement than Asia As? And the reason is the proximity of the spinothalamic and corticospinal tracts. So if you look at where the sacral segments are in the spinothalamic tract, in the topography of the spinal cord, then all you need is 1 more millimeter of the spinal cord to work, and you will regain function inside the corticospinal tract. So it's the anatomic proximity of these two things that if this is working and you have sensory, you have rectal or perianal sensation, then that is why there's a 4x higher likelihood of seeing recovery in the corticospinal tract. Okay, and that just shows it in a different way. Does that make sense? Okay. All right. Next victim. Corey Hartman. Hi, Corey. What are you going to do with your life? What are you, by the way?
PQA5, neurosurgery at University of Florida.
What are you going to do with your life?
I don't know yet. We'll see.
Yeah. Are you thinking like dermatology?
No. I don't know if I'll do a fellowship or go general. I don't know.
Okay. Well, you're young. You've got time.
Yeah.
Yeah. The 46-year-old unhelmeted motorcyclist, C5 Asia C, so now we understand what that means, right? His lowest normal muscle group would be what?
Deltoid biceps.
Biceps. And then the Asia C means what?
That less than or greater than 50% of the muscles, I guess, caudal to that are less than anti-gravity.
Correct. And so he gets this CAT scan, and there's the sagittal reconstruction. And I'll tell you, this is his only injury, okay? And that is all the information you need to make the diagnosis. What is the diagnosis?
So he's got intrathesis probably at 5 on 6. It's either bilateral jump facets or a fracture dislocation.
Well, but you're only allowed to make one diagnosis.
Bilateral jump facets
Wrong.
from fracture dislocation.
Well, what does that mean, fracture dislocation?
He's got fractures of his facets with anterior translation of 5 on 6.
Okay. So facet fracture dislocation. So you're on the right track. You're so close to getting this right. But the question is, does he have a perched facet? Does he have a unilateral jumped facet? Or does he have bilateral jumped facets? Right? That's the fundamental question. Okay? So what does he have?
Bilateral.
You're getting so close there, buddy. All right. What is the diagnosis on the left?
Looks like unilateral perch facet.
Perched facet. What is this?
Jump facet.
Unilateral or bilateral? So how much anaerolisthesis does he have?
He's got 50%.
Okay, so what's the diagnosis?
Bilateral.
Okay, and how much does this person have?
25%.
So what's the diagnosis?
Unilateral.
Exactly. And this is the only picture you need to make that You know this is going to be bilateral. And that is 98% likely to be a unilateral jump facet. Okay. Are you going to give this person steroids?
No.
Why?
There's, I guess, more complications with steroids, and there's no improvement in neurologic outcomes.
Okay, so I'm going to change it because this person was 46 years old. Let's make him half that age. 23 years old, C5 Asia C, unilateral jump facet. Are you going to give that person steroids?
No.
Okay. Who would give this person steroids? 23 years old, unilateral jump facet Asia C. Who's going to give this person steroids? Anyone in this room? One person. Two people. Can I get a third? Nick, you have successfully eliminated the administration of steroids from the world. And therefore, the question becomes, is he right? And I would argue that maybe, but it's a huge leap to do what those guys did. And it's some of my best friends who were involved in the development of the guidelines for the management of cervical spine injury. Okay? But in 2002, back when it was standards, guidelines, and options, it was the option to treat with methylprednisolone in patients with acute spinal cord injuries, undertaken only with the knowledge that the evidence suggesting harmful side effects is more consistent than any suggestion of clinical benefit. Okay? So in 2002, option, you can consider that. In 2013, the administration of methylprednisolone for the treatment of acute spinal cord injury is not recommended. So now we've done this total reversal where, unfortunately, those NASCUS trials created a terrible, terrible situation for more than 10 years, which was if you didn't give a patient steroids, you got sued. Okay? And now our friends have created a situation where if you do give them steroids, maybe you're going to get sued because the guidelines say it's not recommended. But if you understand how guidelines are developed, okay, and you go back to the data that underlies this, which is level 1 data, randomized prospective clinical trials, okay? And the second trial, so the NASCUS 1 was low versus high dose methylprednisolone, no control group. NASCUS 2 compared methylprednisolone versus naloxone versus placebo, bolus plus 24-hour infusion, and methylprednisolone was shown to be effective, but I'll show you how the primary outcome measure actually failed, but it was the secondary outcome measures that showed efficacy, which is a very critical point. And then NASCUS 3 was then the thing that determined that if the injury is less than 3 hours, you give it for 24 hours. If the injury is between 3 and 8 hours, if the administration starts between 3 and 8 hours after injury, then you give it for 48 hours, okay? So those were the 3 trials that were performed. And then if you look at the data itself, no idea how that just happened. What you will see, first thing that you'll see is that what is the most common form of spinal cord injury in the United States in 2015? Does anybody know? Central cord syndrome in an older patient who falls, hyperextension injury in the setting of cervical spondylosis. Okay? So airbags and seat belts and the fact that cars are now designed to be totaled so that the force is absorbed by the hood and the engine block instead of that force being transmitted to the passenger compartment. These things have substantially reduced the incidence of spinal cord injuries from those kinds of injuries. But now we have a bunch of old people with arthritis who are out doing stuff, living an active lifestyle, falling and becoming central cord patients. So that's actually the most common form of spinal cord injury in the United States in 2015 is a central cord injury. But these were studies performed in the 1980s. And back then, okay, this was heavily disproportionately a disease of young males. 86% male, and then look, most of these people were between the ages of 15 and 30, okay? So young males were what were studied for the treatment with methylprednisolone. The primary outcome measure of the NASCUS trials was an improvement in Frankel grade, which is the older terminology for an Asia grade. And by the primary outcome measure, the studies failed. But then they ran dozens of secondary tests. And if you understand that you set a p-value to make it a 5% likelihood that this would just be a statistical anomaly, and then you run 20 post hoc tests, at least one of them should be significant, which is why we are supposed to stay focused on the primary outcome measure, not the secondary outcome measures. But the secondary outcome measures included improvements in motor scores. And what you'll see is that the methylprednisolone group basically led to 5-point improvements in motor scores between 6 weeks and 6 months. And if you improve 5 points, that basically means you're getting an extra level, okay? So in young people who got methylprednisolone, especially in, well, it was really across everybody, but young people got an extra level. And if you give someone wrist extension, you now give them the capacity to operate their own wheelchair, manage their own computer, and even drive. So one level of additional recovery at the age of 20 has an enormous, enormous long-term implication. And that's what methylprednisolone was shown to do. Then what John Hurlburt and Sanjay Dul and Nick Theodore and our fabulous friends did is they said, well, if you look at some of the other secondary outcome measures, which include toxicity, you see increased toxicity. But you're not supposed to take secondary outcome points and make them level 1 recommendations. That's not how the process is designed to work. And that's why in 2002, it was a level 3 recommendation for it being an option. But I still have very serious concerns, even though these are, again, people I respect and consider friends. I have very serious concerns about what happened in 2013. Would you like to add anything to that, Nick?
No, I mean, but same token, let's talk analysis. I mean, we could talk about this all day, but the bottom line is that, the study was ill-designed to begin with. And I think, thinking that there's no doubt that steroids are beneficial. I'll be the first one to tell you that if they're administered before the accident. So if you know you're getting into a car accident, by all means, take the full dose of methylprednisolone before the accident because there's a strong neuroprotective effect. After injury, it's less clear how that plays, and that's based on animal data as well. So the issue becomes, in this case, since the study was poorly designed, when you look at the number of deaths and other problems caused by the administration of high-dose steroids, picking and choosing, again, I'm not going to, and the last thing to realize is this, and even though we live in a very medical legal climate, ultimately the guidelines, and the lawyers love to hang on to things when we don't do things according to protocol. But if you read the opening pages, they are guidelines, and deviation from them does not necessarily mean, and certainly in my mind, does not mean a deviation from the standard of care. If you feel, in that case, based on your practice and the evidence, these are things that are out there right now. The problem is that honing in on the exact patient in whom it might benefit is difficult to do, and indiscriminately using it, on the other hand, is probably worse. So I don't know, I don't know what the right answer is, but I agree with you. And it was agonizing. And to the point of between 2002 and 2013, it's been an evolution. I think we've known more. And there are more studies than just this that show the complications related. And there are other studies, again, weren't powered that showed no effect of steroids. So while that was a big study, there are issues with it. I think one thing we've learned is that we can do better at studies, and that ultimately going forward, it's unfortunate because we had an opportunity and we didn't seize upon it.
I would be comfortable with a level 3 recommendation that says steroids are not recommended.
I wouldn't disagree. I think there was a lot of internal debate, and John Hurlburt makes a very powerful case, and as you sort of walk through it, again, that assignment as level 1 on the other side, is a forceful statement. I think it's supported, although I respectfully agree in your point that there are good arguments on both sides of that, and I don't think it's going to be solved today.
No.
Unless we take it outside, Dave.
Yeah. Well, you just had the massage, so I'll have the.
I'm ready to go.
All right. Okay. Katie Miller. What's up, Katie?
So listen, David, he means outside of the parking lot. So I don't know, you want to go there.
What do you want to do with your life, Katie?
Taking a fellowship, but I haven't decided what yet.
Right on. Okay. And are you in neurosurgery or orthopedics?
I am neurosurgery. I'm a 6th year.
Okay. So, 46 years old, in the trauma bay, Asia C. Are you going to intubate him? C5 Asia C.
I would not.
Okay. What criteria would you use to make that determination?
I think I would figure out what we are going to do with this patient, but I would hate to lose my exam if we have a good exam until we know our final plan.
That is a fantastic point. That is the precise thing to consider. So, what treatments are you thinking through when you say that?
If you want to put him in traction and distract him.
Right. So traction is safer in the awake examinable patient, right? So if you're thinking to yourself, I'm going to put this patient in traction, it's one of the things you want to consider. If I can avoid intubation, then that intervention is safer in the patient who is not intubated. So you're exactly right, okay? But who should get intubated? And we all know that C3, C4, C5 keeps the diaphragm alive. The intercostal muscles from T1 to T11 innervation, abdominal muscles in the lower thoracic region, and then accessory muscles in the cervical region. And if you look at what predicts the need for an artificial airway, it's usually related to respiratory compromise. So the upper cervical injuries obviously have a high rate of respiratory failure. If they don't fail immediately, like a C3 is probably going to fail in the field. If they don't fail right away, they fail through fatigue. Because they may only have the diaphragm, they don't have accessory muscles, and so they fatigue, and then they go into respiratory failure down the road. Hypoventilation, secretion retention, and then these are often not isolated injuries. So if you also have bilateral pneumothoraces and a cervical fracture dislocation, the likelihood that you need to be intubated is going to go up sky high. And then if you tuck away one thing, you should remember that it's not until you get to a level of T11 that both the cough and the functional vital capacity in the acute phase are normal. So both cough and functional vital capacity are diminished in every single level of injury above T11. And in fact, up in the upper cervical, it's that small. Mid-cervical, 10 to 15% of your normal functional vital capacity. Over time, the accessory muscles get stronger and functional vital capacity improves over time, but acutely, it's a very, very significant decrement in functional vital capacity. So cervical injuries very frequently end up getting intubated if they're not intubated right away. And they also end up getting trached because they're, I don't know why it keeps doing that. Just going backwards like 10 slides. They don't have a normal cough, so they're not protecting their airway. Okay? So they end up getting trached. If you have a C5 Asia C, do you know what the likelihood of that person getting trached in the first week is?
I do not know that.
90%. C6 drops a lot. C7 drops further. C5, 90% likelihood that that person's going to get trached. If they are CO2 retaining, if they have a respiratory acidosis, or if they have tachypnea, those are reasons to consider intubation. But if you can hold off on the patient that you want to put in traction, it's much safer in the awake communicative patient. And then you have to assume that patients who are C4 and above are going to get intubated. And if they're Asia C or worse, they're going to fail to maintain a respiratory effort in the acute phase. Okay, so whether I intubate this patient is going to depend on what I choose to do next. Okay? You want to keep going? You're doing well. What are your treatment options for this?
I think in the acute setting, I would put him in traction and reduce that.
Okay? So that would be, if I asked you, what are you going to do? That's what you would do. If I asked you, what are the treatment options?
Yes.
Then you want to give me the menu.
Right. You can go from an anterior approach and do a 5/6 ACDF. You can do a posterior instrumentation infusion.
Uh-huh. I think it's C4-5. But,
Oh, sorry.
right?
Sorry.
1,
Yes.
2, 3,
Yeah,
4.
sorry.
But, yeah.
4/5.
Okay, so your treatment options are, you said traction, you said a C4-5 ACDF.
Posterior fusion.
Uh-huh. And if you went posteriorly, what would you do?
You do lateral mass screws at those levels.
Yeah, what are you going to do before you do that?
Reduce them in the OR.
Yeah. So let's say you try traction or you don't try traction, you just say, oh, I'm just going to operate on this guy posteriorly. If you just drill the top of this facet right there, if you just drill that little triangle, then this thing just, boop, just pops right back. And then the facet is often injured in a way that it doesn't accept a screw. Okay?
So you extend your construct then.
Yeah, so if you're going posteriorly, you're usually going to do 2 above, 2 below. You have to be prepared to do 2 above, 2 below because you may not be able to get a stable construct at the level by just instrumenting the level of injury. Okay, so that's exactly right. You can close reduction, anterior, posterior. Okay, let's ask Kenneth Crandall. Where is Kenneth? What's up? How are you? In the interest of time, I'm not going to ask you about yourself. The initial closed reduction of cervical fracture dislocations, okay? Is it safe?
It's safer in an awake patient where you can examine them like we've talked about already.
But either way, is it safe?
Yes.
Yes. Do you need to get an MRI first?
I don't think it's necessary in a patient who has a complete spinal cord injury. But in a patient who doesn't, then and you're at a center where you can get a fairly rapid MRI scan, like we're able to within usually an hour or two.
Yeah.
I think it's a good idea to make sure that there's not a big disc fragment or extruded disc fragment there.
So when you're sitting for your oral boards, right, and you're sitting across from Praveen, and he's, stoic and they give absolutely no feedback, right? And you walk out of there and you don't know whether you just made a complete fool of yourself or whether you nailed it because there's literally zero, they're just for 8 hours. What they're looking for out of you, they're looking for the logic train, right? They want to make sure that you are someone who understands the principles to make good decisions, okay? So what you just said is actually a fantastic way of communicating what your thought process is with this. You wouldn't give all those options. You would say, well, I practice in a center where an MRI is readily available, and so because this person has an incomplete injury, I want to get an MRI first. Or if they gave you a scenario of a complete injury, you're going to say, look, this person's already complete, time is of the essence, I'm going to skip the MRI and I'm going to go straight to surgery. Whatever it is, you just have to have a sound rationale for the defense of your decision making so that you are demonstrating that you're safe, okay? And my personal bias, because no one knows the right answer to this question, my personal bias is very similar but not exactly what you said. But let's just think about this for a second. As it turns out, it actually is safe. There's a 1% incidence of new permanent neurologic deficits in response to closed reduction, and a 1.7% incidence of transient deficits, okay? If you look at whether an MRI is or is not necessary, the data is a lot more variable, but by and large, the gestalt is that an MRI is not necessary. And you also need to bear in mind that reduction does not necessarily mean decompression, because this is the thought, right? That when you get them back into alignment, that you have opened up the canal and decompressed neural elements is the thought. But Alex Vaccaro published a really nice, in his paper where he looked at closed reduction with and without MRIs. Here was an example of a pre and post reduction MRI where the compression actually got worse. Okay, so you have to be careful about closed reduction should be a prelude to your definitive intervention. And it should only be the treatment in and of itself if someone has some other reason. The person who is in hemorrhagic shock and just had a splenectomy and has a grade 4 liver lac and, has a lactic acid of 20, and that if you have to put that person prone, they're going to die because they have an open abdomen. Okay, yeah, traction is a very reasonable thing to do for that patient until you can clinically deal with this definitively. But traction should be viewed as the prelude to your definitive intervention, okay? 26% of patients failed to achieve reduction with traction, which means that 74% were successful. And it also means that the rest of the world is just a lot better at this than I am, because I think that I have a 75% failure rate instead of a 75% success rate. I don't know what others' experience is, but what do you think, Nick? How frequently are you successful with cervical facet fracture dislocations? Fail or?
No, successful. Probably,
Yeah.
I would agree with that. But you actually have to put weights in people
Oh. Well, that makes a lot more sense now. No, look, I don't know what it is. I'm not as good at this as other people for some reason. I'm just not. Or maybe I'm a wimp because I'm just nervous at some point where I'm just thinking. Plus, I do this in the operating room. We just take them up to the OR, put them on the OR table, do the traction there, and then if it works, then we put them to sleep, do an ACDF. And then if I'm not successful, then I decide, am I going to just flip them and do it posteriorly to get them reduced? Because I am better at getting them reduced through posterior approaches if they have failed to reduce with traction. Or maybe I'm just impatient. I don't know. Charlie?
Do you flex them a little bit when you try to reduce them?
Yeah, if the patients are awake, I try to give them muscle relaxers and some fentanyl. And then, do some flexion and distraction.
Okay. Yeah, because I think that's the other thing is that if you do it straight in the OR, there may not be enough time for muscle relaxation to occur. Like, so say for instance, if you do it several hours prior to the OR, or maybe not several hours, but a couple hours prior to the OR, and try to give them muscle relaxation with a little bit of a vector of flexion with the traction, it might gradually slip into motion. Whereas if you do it acutely, it's less likely. I think
we should give them the muscle relaxer in the trauma bay so that it's kicked in by the time we get up to the OR.
Yeah, maybe.
Okay. All right. There is no right answer to this question, okay? So in full disclosure, these are my biases. Personal opinion. This is not right or wrong. But I can defend this to anyone who asks me. I already passed my board, so I don't have to do that, but you will, right? Okay, so closed reduction without an MRI if there's a neurologic deficit. And so I group completes and incompletes together. If you have a neurologic deficit, in my opinion, the goal is to get the pressure off of your neural elements. And so I'm not going to waste the time in the incomplete patient or the risk of putting them in a tube where you can't, examine them. So anyone with a deficit, I'll just do it closed without an MRI. I get an MRI if they're intact because the only thing that you can do is hurt them. Okay? You can only make them worse. And then I attempt awake closed reduction first. And then if you're in the operating room, you can actually use neuromuscular blockade because that's the first part of a rapid sequence intubation, right? If unsuccessful. And then for me, because I've never been good at sticking the cob in and turning the cob and getting it to do that, or Caspar pins, and if I can't get them reduced through traction, I have struggled to get them reduced through anterior approaches. So if I am unsuccessful at closed reduction, I do a posterior approach. So that's my bias for this injury pattern. And I'm going to stop there.
Question.
Yeah.
So with your posterior approach at that time, will you instrument them posteriorly and then do an anterior and then go back to posterior and put in rods, or do you just do posterior?
I have started, well, I now view this injury as more of a total failure picture because you have to have disruption of the capsular ligaments, you have to have disruption of the posterior elements, you have disruption of the disc space. I mean, these are the easiest. If you get them reduced and then you do an ACDF, it takes like 30 minutes to do the entire operation because once you open them up, the disc is already totally disintegrated, right? And then you just scrape out some end plate, put in a graft and a plate and go home. It's the fastest ACDF. The ACDF after successful reduction of a cervical facet fracture dislocation. So the disc is gone, the capsular ligaments are gone, the joints are gone, the posterior ligamentous complex is gone. I have really had this pendulum swing towards doing 360s for everybody. And whether that's posterior and then anterior or anterior then posterior, I've really heavily moved towards 360s for everybody for this. And again, that's a personal bias. It's not right or wrong to do posterior only. And in fact, there's plenty of data that shows that they're all equivalent. Posterior is equivalent to anterior is equivalent to 360. But I've had a few people where I just did one or the other who have failed. And so I now basically treat this as a total spine failure 360. Any other questions? Yes, sir.
I showed it in the CTA on these patients before surgery.
No, we do not necessarily. Well, we've become so good that that so many of these patients have already had their CTA before they're even off the table, before we even consulted, you know. And this is absolutely an indication for screening for blunt cerebrovascular injury. The way it's supposed to work in our institution is if someone has an intracranial mass lesion that requires emergent craniotomy, you're not even supposed to do any other scan besides they just do the cervical spine, so we know that we're not about to position someone who has a facet fracture dislocation, but they don't do the rest of the trauma pan scan. If there's an intracranial mass lesion, they're supposed to, and the expectation in our hospital is that from the time they reach the trauma bay to the time we make a skin incision in the OR is 40 minutes or less, is the expectation in our hospital. And so if someone has this and has a neurologic deficit, we will operate on them right away as well. And so they should not waste the time for a CTA. You can always get that later. But oftentimes it's already done. And then I don't bother dealing with that. If there's blunt cerebrovascular injury, I will treat that afterwards because they're going to want to put them on aspirin or sometimes heparin, right? And I'm going to want to already have my operation over with. So whether there is a CTA or not, it doesn't really matter to me because I'm not going to use that information in any meaningful way until after the surgery. Any other questions about this or anything else? All right, we're back on time. Thank you.